happy to be here with you all, and I'm going to talk today about levels 6 and 7 nodal contouring. I've included a couple of pictures throughout my presentation from some travels I've been fortunate enough to do in Central and South America. So you can just sort of ignore those, but I just like to include some pictures sometimes, often to my family and talks that I give, but I thought for this it'd be fun to put some photos of your beautiful part of the world. So I don't have any disclosures. So you all might be thinking, I know you've had other talks about levels 1 through 5, and you might be thinking that, this is probably the most boring one and not that important, but actually correctly contouring levels 6 and or 7 can be crucial for several subtypes of head and neck cancer. And just as importantly, for other types of head and neck cancer, actually choosing when not to include level 6 and or 7 can be equally important in reducing toxicity, short and long-term side effects for our patients. I just want to check in, is this pacing okay for translating, or should I speak more slowly?
We are perfect.
Okay, great. So here's what we're going to cover today. We'll really cover each nodal region separately. We'll cover 6A and 6B, and then we'll do several practice cases. Then we'll turn our attention to level 7, 7A, and 7B. We'll do some more practice cases. We'll finish with 1 or 2 practice cases that encompass both nodal groups, and then we'll have a brief discussion about organs at risk. And if we have time, I have an extra case for us to go over at the end. So a few abbreviations to make sure we're all on the same page. I think these are all commonly used, but I just wanted to include them here. So if people are referencing this later, or just for everyone following along with the presentation, I didn't want anyone to get lost. So we have nasopharynx, oropharynx, hypopharynx, oral cavity, lymph node, and node positive. So we'll start with the level 6 lymph nodes. These are basically the prelingual and paratracheal lymph nodes. We'll talk in detail in just a couple of slides about their borders, but I do have them listed here, and I have some pictures as well to sort of get a gestalt of where these nodes are in the neck. So why do these nodes matter? They are much less commonly contoured because they're much less commonly involved or at risk compared to levels 1 through 5. And it can be easy to get lulled into complacency. In my practice, I see a lot of oral cavity and oropharynx and early larynx cases, and typically those cases don't require level 6 contours. But for several other subsites, which we'll talk about, and very notably thyroid cases, it's very important, it's critical to correctly identify and contour and include these lymph node levels. So level 6A lymph nodes drain the skin of the lower face and the anterior neck. There are several situations when you will need to include these. So for very locally advanced, or particularly for node positive cancers of the lower lip or chin, which are rare but happen, these actually can be a first echelon of nodal drainage. They typically would pass through 1A or 1B on the way down, but you can't get skipped passes all the way down, so you'd want to include it in those situations. If there's a tracheostomy in place, there can be tumor cells that are directly in this area, and so this needs to be covered. And then similarly, cancers that directly invade, usually from the posterior anterior into the space of the level 6A, but we also need to cover this space. And then there are several cancers when level 6B is indicated, particularly thyroid, the apex of the piriform sinus, and the hypopharynx, and with subglottic involvement. And for all of those, we typically cover level 6A as well. Here's a quick picture of Rio de Janeiro. Level 6B sits, for the most part, just posteriorly to 6A. This also drains that lower lip, but also the floor of mouth, the anterior tip of the tongue, although we don't tend to think of that much for that cancer. But again, notably thyroid, the glottic and particularly subglottic larynx, the apex of the piriform sinus, and the cervical esophagus. So again, very important to include this for thyroid cancers. If there's hypopharynx involvement of the apex of the piriform sinus or the post-cricoid region, which is uncommon, or if you have node-positive hypopharynx cancer, all these would be indications to include this level 6B. And then laryngeal cancer with subglottic extension, or if you have locally advanced laryngeal cancer. And then for cervical esophageal cancer, it's really sort of a different subsite. If you're in a really subspecialized environment, you might have GI specialists treating that cancer, but it's honestly, it follows a lot of similar rules to head and neck cancer. And then again, as we talked about, locally advanced and particularly node positive lower lip and floor mouth cancers. So again, it can be just as important not to accidentally include these or over contour. My rule for head and neck cancer when I'm teaching residents and for myself is when in doubt, I think it's better to over contour, because the cardinal sin in our field is to miss the cancer. And so I think it's certainly preferable to contour only what's needed. But if you are on the fence, I do recommend going a little bit bigger. But there are some cancers and in a lot of situations they run into where you can feel really confident that you don't need to include these level 6 lymph nodes. So for standard nasopharynx, oropharynx, and oral cavity cases, again, excluding those slightly rare tip of tongue and floor of mouth oral cavity cases, you can feel really confident that unless you're seeing, a massive amount of cervical lymph node involvement and you're concerned with that things are potentially tracking in that direction, just for standard cases, you do not need to include either of the level 6 lymph nodes. For supraglottic larynx cases, not need to include. For salivary gland cancers, you don't need to include. And then the vast majority of hypopharynx cases do involve the piriform sinus. But if you're confident that the apex of the piriform sinus is not involved in a hypopharynx case, and there's not a lot of lymph nodes, which would be a rare hypopharynx case, then it's reasonable to exclude them as well. So level 6B is really sort of can almost blend in. If you sort of draw your level 4 contours a bit more generously medially, then it can kind of end up including part or most of level 6B. And again, I would always rather have, if I was the patient, I would rather have my doctor err on the side of treating all my cancer than trying to be really tight and potentially missing cancer cells. But if you become comfortable purposely excluding level, it says 4B, but it should say level 6B. If you're comfortable purposely excluding level 6B, then that will help your dosimetrist get you a better plan that can better spare the pharynx. That can drive less short-term and long-term toxicity for our patients. So a quick note on the piriform sinus, because again, the vast majority, probably over 80% of hypopharynx cancers do arise in the piriform sinus, but there is this subtle distinction between the apex, which is the bottom of the piriform sinus, and the entrance of the piriform sinus, and the nodal drainage patterns are different. And so technically, if there is an early stage or even just an exophytic growing superiorly hypopharyngeal cancer that does not involve the apex or again bottom of the piriform sinus, then it is not necessary to contour level 6. As I've touched on a couple of times, when in doubt, I think it's appropriate to cover level 6. It can be quite challenging on scope exams and imaging review to assess if the apex is involved versus just piriform sinus. Often these tumors are fairly locally advanced and you can feel pretty confident that it likely is. This is a great opportunity to sort of take a multidisciplinary approach and discuss with the head and neck surgeon as well that would have gotten the biopsy. And if you are thinking that the tumor is small and maybe isn't involving the apex and you verify with the head and neck surgeon, then again, in these select cases, it could be appropriate to exclude level 6. But otherwise, I would lean towards including level 6 for piriform sinus or for piriform sinus cancers. Here's the Atacama Desert. So now we'll get into a bit more details about level 6 contouring. We'll start with level 6A. So the way I think about level 6A, these are the lymph nodes on the very front part of the neck. They basically superiorly, it starts where level 1B stops. So just below the caudal edge of the hyoid or the submandibular gland. The lateral borders are very distinct for, I would say in general, actually the borders for this specific nodal site are quite distinct. And so the lateral borders are the sternocleidomastoid muscles. The anterior border is the skin. Posteriorly is the strap muscles. And then inferiorly is the top of the manubrium. And you can see a couple of representative slices over to the right side of the slide here. I will be going through more slices in just a minute. So for level 1B, the contours are fairly straightforward, I think, when you look at them visually, but when trying to talk through them, or if you're reading about them, it actually is quite wordy, because they cover a large amount of sup-inf area of the neck, and the anatomy is changing, and so the definitions of the areas tend to get quite wordy. But essentially, they start at the bottom of the thyroid cartilage. They extend basically to the borders of level 3 and level 4 at the common carotid. Anteriorly are the infrahyoid muscles. Posteriorly, the way I tend to think of these, particularly if I'm contouring something like a thyroid cancer, where I really want to make sure these are well covered, is I just think of this as the anterior vertebral body. I listed the very long definition of the formal anatomic posterior borders, because it does change as you're traveling sup-inf in the neck. And we'll look at these in a lot more detail in just a minute. But I think if you keep that, you certainly don't need to go behind the vertebral body, of course. But if you're contouring a thyroid, that's a reasonable place to go for this. You can be a bit more petite, and you are contouring for other disease sites. And then like all the other neck node contours, these formally end at the top of the manubrium. So what I'm going to do now is I'm going to bring over a list of nodal contours. So I've linked to this at the end of the slide deck, but this is basically a Green Journal article that came out about 10 years ago, but I think it's still the gold standard. They went slice by slice every 2 millimeters from the base of skull down to the mediastinum, really contouring assiduously every single nodal region. And so I still use this in clinic if I have a patient with difficult anatomy, or if I'm trying to figure out borders. And so I'll be referencing this a couple of times. This, of course, is where I took the screenshots as well, but I just wanted to take a couple of minutes here and go through. So basically here, you can see I'll make this a little bit bigger so it's hopefully easier to see, but you can see that we're starting here in the basically level of the supraglottic larynx, and you can see we have level 2 and level 5, and that in blue and yellow, and then the purple is level 6A. The one thing that I will say about these slides is they do, if you're scrolling through on a computer, the top slides are inferior and the bottom slides are superior. So it sort of goes bottom to top. That's just generally not how I tend to think of things and how other tools that I use are. So I've actually started us in the middle here. I'm going to scroll up in the computer, which is inferior anatomically. But just to sort of point it out here, here's the last slice with level 1. And then again, the very next slice, level 1, as we transition out of those submandibular glands and digastric muscles, are now getting into level 6. And then we can see it's just a pretty clear where they're starting here. You can see over on the right side of the screen, patient's left, that's the bottom of their submandibular gland. So you technically could have put a level 1B there, but then that disappears, and you can see it's just basically a band. The formal definition of level 6A is going out to the skin, but you can see here they're really staying inside the platysma muscle, which I think is reasonable at this higher level. And then as we keep going down, you'll see that, of course, it depends for our patients. Often our patients have much less fat than this patient does. And so there's not such a big area between the platysma and the skin. So you can go down here, you can see this remains a very sort of straightforward. You could almost, for a lot of patients, just take a 5-ish millimeter brush and go across like this, and that basically gets you level 6A. That's quite straightforward to contour. And then as you get down here, as you get down below the cricoid, we'll start seeing level 6B coming into play. So that's the purple right here. And again, there's a lot going on here. Often when I'm contouring, I'm often kind of, if I'm just doing level 4, I often don't stop right here. I often will, swing somewhat wide, but what I would say, and I think that's fine. We're now just at the top of the cervical esophagus, which would be right here. But sorry, I just want to verify. Everyone can see my mouse, correct?
Sorry, Chris.
Sorry, I just want to make sure you can see my mouse when I'm circling things on the screen.
We are seeing perfect.
Okay, beautiful. So the esophagus is here. And so again, if you were to over contour and include 6B here in a case that clearly didn't need it, let's say like an early stage pharynx or a oral tongue, that would drive more dose. It'd be really hard for your symmetrist to spare the cervical esophagus here, which would drive more short-term and long-term toxicity. So sparing it, I think, when appropriate, is very helpful for the patient. Covering it when appropriate is even more important, of course. So basically, you can see here, it's contouring this as cleanly and as clearly as they've done in this is just very difficult and would be extremely time consuming to do in clinic. So usually the contours are going to be a little bit less, just without all these complete twists and turns. And then often for locally advanced cancers and the hypopharynx or larynx, we're often covering down to the first level, the first tracheal ring. And so really this whole region here would end up being covered. If it's not a thyroid cancer, then I think it's very appropriate to basically come back and then carve out the esophagus and then cover an area like this. If it's for a thyroid cancer, typically we'll take the entire area. And if it's a hypopharynx cancer, we do typically cover generously inferiorly as well. So you may, depending on where the patient's exact anatomy and where the primary is located, you may end up tracking down into at least the top 1 to 2 cm of cervical esophagus as well. But I think when appropriate, again, you do want to purposely exclude the cervical esophagus, either entirely because you're not covering level 6B when appropriate, or even if you are, even excluding it to the degree they are here, will help your dosimetrist push some dose out of that area, which will ultimately improve toxicity for your patients. So just scrolling down here, it gets fairly repetitive as we get further down into the neck. A lot of patients do not have this sort of beefy prevertebral muscles, and so these contours end up sitting a bit closer to the anterior edge of the vertebral body. And you can see here that there is some of this level 6B that does track right adjacent and really even can almost be posteriorly to the esophagus. And so that's why when you're covering particularly a thyroid primary where these are really first echelon, you just don't want to miss. And so most people will contour really this just whole thing because it's hard to not miss unless you're really looping out and having the esophagus included. So now we're getting into the low neck. You can see again, as the esophagus moves laterally, the nodal space on the patient right rather, does track more medially behind the airway. And then I'll be watching for the top of the manubrium will be coming into view quickly, again, tracking even more medially here, which again sort of drives the contouring. Usually in clinic, you're going to do something more like this for a thyroid primary. And as we get into the thoracic inlet here, you can see that, again, we're sort of staying really more like platysma, not going all the way out to the edge of the skin here. I think that's appropriate, and I agree with the way this is drawn here is how I try to draw up my level 6As in clinic. Again, lots of our patients don't have this much fat here, and so the skin ends up being right here. And then once we hit the manubrium, the contours do stop. I will note that, on this and other teaching tools, the contours stop at the manubrium. For selected cancers, it can be appropriate to continue the contours more inferiorly. So that would include thyroid cancers. For anaplastic thyroid, we like to go all the way to the carina, so that's much farther inferiorly. For others, we often will go to the arch of the aorta, but including these mediastinal nodes is appropriate also for very advanced subglottic or hypopharyngeal cancers with significant nodal burden. It's also appropriate to go lower, but those again aren't formally part of the lower neck lymph nodes. Okay, so back to our presentation here.
Chris, I have a question.
Yes, please.
How often do you treat thyroid cancer patients?
Great question. Very infrequently. It is not common in my practice at all. I'm curious actually for you or even the broader group. I don't know the best way to answer this on a large Zoom call like this, but is this a cancer that's commonly treated with external beam in your practices?
No, not so much. That was what I was curious about, if that's different in the US. I think we have labs, we have lost some space in thyroid cancer patients, and we don't treat it any frequently.
Well, I think, I-131, radioactive iodine is such an effective treatment for many types of thyroid cancer. I would say I probably once a week get a question from patients at all these sites about, are they going to be radioactive because they know someone who got radioactive iodine and had to sequester themselves for a week. So that's probably my most typical interaction with thyroid cancer, to be honest. But the one that we do see, unfortunately, a couple times a year for most of us in practice is an anaplastic thyroid, which usually have very poor outcomes. But that's probably a kind of separate talk about trying to deal with that disease site.
Chris, we have one more questions from
Please. Yeah.
people. In patients with a lot of fat space in the anterior head, how do you use the last boundary of the level? How do you set the boundary?
So patients with a lot of fat where, sorry?
In the anterior head. That's the question.
So yes, basically with really, really a lot of fat on their neck. So there's a muscle called the platysma muscle that is going to be exterior to basically all the vessels, muscles, and organs of the neck, and that's going to be posterior to the fat and skin. And so usually I would stick behind the platysma muscle.
That's perfect. So then we take care of the platysma to set that field.
Yes.
Thank you.
Great questions. Any others before I go on?
Not so far.
Okay, so we have our first Zoom poll question, which is going to be, which of the following is the correct way to contour both level 6A and 6B?
Perfect. We're going to wait for one more seconds to have
We'll get
list.
to somewhere close to 100.
No sean penosos. Vamos adelante. En el chat están poniendo varias respuestas. Les pido si pueden, por favor, ponerlas también en pantalla.
Okay. Okay, perfect. So we're basically there. So I think it looks like the vast majority of you found the correct answer, which is B. So answer A is only 6A, and then answer C is just a slight over contouring into the sternocleidomastoids laterally for 6A, and then D is a slight over contouring. Again, we've been talking about trying to give your dosimetrist some ability to at least partially spare the esophagus. If you were to 6B like this, then they wouldn't really be able to, it would be harder for them to exclude the esophagus. Again, in real life, when you're treating, a subglottic primary, oftentimes this area does end up getting treated anyways because of your coverage of the larynx and tracking inferiorly. And then I will say that this is probably a much more typical look of what level 6A. You can see there really is no space between that platysma and the skin. I know we talked about sort of the other end of the spectrum just now when there's a lot of fat, but most head and neck patients are really at the more cachectic or certainly thin end of the spectrum. Okay, so now let's get into a couple of real world contouring examples, because again, when you're putting these contours in on your actual patients in clinic, they end up looking differently, of course, than what we just looked at, because you are covering the primary, covering adjacent nodal sites. So I've taken several example cases out of Nancy Lee's excellent basically guide to IMRT. And again, I have a link to that at the end of this slide as well. I think it's a fantastic resource. But this would be a patient with a T3 larynx cancer with subglottic extension. So again, that subglottic extension buys this patient level 6 coverage. It also, of course, the larynx cancer buys them coverage of the entire larynx. And here, the subglottic extension are going down to the first tracheal ring. And so you can see here they're covering level 6, basically all these areas here. You can see the way they've drawn this, they probably could have been a little more careful, in my opinion, about, they've basically split the difference. So really a slightly more careful drawing of level 6B, they could have swung down to here, up here, and formally exclude the esophagus, and down like this. But you can see that basically they are excluding the cervical esophagus for the most part here, which again will drive less toxicity for this patient. Here is another example. This is a patient with anaplastic thyroid cancer. They got a resection, and then this is going to be post-operative chemoradiation. But just not to get too much into details, but I just want to show so you can see basically as soon as level 6 starts here, that's included. It's included all the way down. Again, it looks less formally defined. It looks like they're just actually sort of maybe overdrawing the larynx, but as part of that sort of big volume here, they are purposely including level 6A. And then they also are doing a much more generous coverage of that level 6B. So we saw in the last case, if we just go back quickly, we can see there is sparing of the esophagus, whereas here, there is no esophageal sparing. They're being much more generous in covering that. And again, that's to ensure they're not missing any of those 6B nodal regions. And then again, they are tracking down more inferiorly in the neck, below the formal definition of cervical lymph nodes for this specific cancer, which is an anaplastic thyroid. And then here's just another variant. So this is a patient with sort of multiple recurrent papillary thyroid cancer. And I will say this is probably the other situation. Again, it's niche, only maybe one patient a year in any of our given practices at UCSD, but where we'd see a sort of just a bad actor of a thyroid cancer that for whatever reason keeps recurring locally, but isn't spreading. And oftentimes this is, after multiple surgeries, we will end up using external beam to try to completely eradicate the disease. And so I just am showing this because you can see actually a site of recurrence here. This is why we have to cover so far back when we're covering with external beam. You can see this is totally posterior to the trachea, and it's really hard the other lymph nodes kind of come around to this side. So it's really hard to exclude the esophagus and get adequate coverage. I will say that I would disagree a bit with the contour. I don't know all the details of the patient, but I was surprised to see, if we look on this slice right here, there are very skimpy coverage of basically no margin on gross disease there. So I was a bit surprised to see that on this, but I do think it's just worse. Sometimes it's nice to see when we're always empirically covering regions. Sometimes it can be helpful just to see actually what disease looks like in that area. Okay, we're now going to try another interactive piece of this. So this is a patient of mine from a year or two ago with anaplastic thyroid cancer. He could not get a resection. So the GTV is marked in orange here. And I would like everyone to please use the annotate tool and do your best to sketch out what you would put as an elective CTV for nodal coverage at this level.
Bueno, vamos a invitar a todos a que en la pantalla, en la parte inferior izquierda de la pantalla van a encontrar un lápiz que dice anotar. Entonces los invitamos a todos para que por favor seleccionen. Chris, do you want us to contour only the lymph node space or also with the tumor?
I think it's helpful just to kind of see what everyone's thinking in general, but what I was thinking is that everyone would cover basically it ends up being one whole volume, and I think it's fine to put in the 2 lymph node volumes, and then you could boolean in the GTV. But I was thinking that people would put in the level, the whole volume.
Okay, because we are having a lot of responses.
Yeah, this is great. I think it's really interesting to see how this looks. I'll give it maybe 30 more seconds.
Perfect. When you think
And I know it's really hard to using the Zoom tool. It's never going to look as pretty as it does when you're, at your work computer in your formal contract program. Okay, perfect. Well, thank you everyone for your responses. I think this is great. Gives us some great talking points. So I think they're going to stay. I'm going to go to the next slide, which has my contour on it, but I think they'll all stay. Yes. So my contour is in green. You can't really see it clearly. Don't worry too much about this patient had a lot of neck lymph nodes on the right and left. So that's why we're going over here to level 5, which I didn't tell you about. But what we're really looking at is this central region. And if you can see this, this is what my contours look like. You can see they go back here, and then I do come down, swing down, and include the whole esophagus. So this is, and it's tricky because I know I've been kind of emphasizing that we want to try to spare the esophagus, but this would be a situation where we go really big in the contours, because again, these lymph nodes can track back. That level 6B tracks all the way back here, and in the sort of gold standard reference we were looking at earlier, the esophagus had already moved more laterally here, so it's a bit more sort of obvious that there was a nodal station back here. But for thyroid cancers, this is where you want to make sure you're coming all the way back behind the trachea, behind the esophagus, because there can be nodal recurrences all the way back to that area. And then here, I might have been a little generous, honestly, in my contours. You probably could have ended about here on this 6A, which I think a lot of you did, and that would be very reasonable. Okay, here's Las Flores surf break in El Salvador. So here would be a case from e-contour. I'm seeing it's already 8:45, so I'm not going to go through this case. I want to make sure we have plenty of time for level 7. But if we have time, we can come back to this at the end. I will just point out that you can see basically the inferior, or sorry, the posterior contours here that again are including those at-risk lymph nodes that are posterior even to the esophagus for thyroid.
Chris, we have one last question from before this. Someone is asking in which cases you will go for the 6th level inferior to the manubrium. Is there any case where you go inferior? Can you please?
Definitely. So sorry, I probably should have put a formal slide in this. It's a great question. So thyroid cases, and basically always, especially if there's lymph nodes involved that are sort of low level 4 and or level 6 lymph nodes involved, you'd want to go at least a couple centimeters inferior to the lowest lymph node. Kind of a lot of the protocols and formal guidelines will talk about going to the aortic arch, top of the aortic arch for non-anaplastic thyroid, and then going all the way down to the carina for anaplastic thyroid. So that would be the classic one where you're always going to go lower than the manubrium. And then for subglottic or hypopharyngeal cancers that have significant nodal burden, particularly that are nodes that are approaching that thoracic inlet, I would also go lower. I would go, at least 1 to 2 centimeters below the lowest level, the GTV, nodal GTV, which often can be below the manubrium as well.
Thank you, Chris. Thank you so much. Go ahead.
It's a great question. Okay, so for our second Zoom question here, which of the following primary sites are most likely to include level 6 nodes, and which of the following are less likely to require? So basically, what you're looking for is the thing before the semicolon is when should you include level 6, and then the second one should be what you don't include level 6.
Bueno, tenemos la siguiente encuesta en vivo, que va a decir cuál de los siguientes sitios primarios son más probables para incluir los niveles ganglionares 7 y cuáles serían menos probables que requieran tratamiento para incluir, perdóneme, los niveles 6, qué pena, fui yo el que se equivocó. Son los niveles 6, confirmo. Así que adelante, por favor. Please, 10 more seconds, please. We have 25% of participants. Adelante, por favor, pueden votar.
Okay, perfect. So we got close to 100 here, participants. So again, the vast majority of you correctly identified answer A. So yes, thyroid is sort of the classic level 6, although again, we don't see it that often in our clinics. And then it's very rare for an oropharynx cancer to require level 6 coverage. I think that's why level 6 is something we tend not to see. We see lots of oropharynx patients, very few thyroid. So yes, that would be the right answer. B and C both say include for oropharynx, that would be wrong. Exclude for floor of mouth cancer. Floor of mouth is a much more rare subsite, of course, but that is one where we want to think about level 6A coverage and potentially 6B. Larynx cancer, we would think about, particularly for subglottic larynx cancer, we'd want to include level 6, or for locally advanced glottic larynx. And then include for lower lip cancer is correct for D, but exclude for oral cavity. That one probably is, and I see that was the second most common. That one's actually sort of right too, but there are these, again, floor of mouth, which is an oral cavity subsite, and tip of tongue would technically have level 6 drainage as well. So that level D was a bit tricky because that one was mostly right. Okay, here's La Paz, Mexico. Okay, now we're going to move on to level 7. So we're going to be in a different part of the neck now. Level 7 is in the superior neck. And these nodes actually are, I'm excited to talk to you about them because they get a lot more action in our day-to-day contouring than level 6. These are the retropharyngeal and retrostyloid lymph nodes. And it was hard to find really good pictures of them because they are in the deep portion of the neck, close to the skull base. But we'll look at a lot of axial imaging as well and try to get a better handle on these. So these lymph nodes definitely matter. They need to be included in many head and neck cases. So they often get grouped together with level 2, but they are actually a distinct node group. So these are critical to include in any tumor that involves the pharyngeal wall. So that's going to be all nasopharynx and hypopharynx and some oropharynx. And as well, any tumor subsite that has involved bulky ipsilateral level 2 disease. So we'll talk a lot more about all that. So here is level 6A. That would be the light green that's pointed out by the arrow here. Formerly, this drains the nasopharynx, eustachian tubes, and soft palate. So it absolutely needs to be included in all nasopharynx cases. You'll often see, if you treated much nasopharynx, you've very likely seen patients with these retropharyngeal nodal metastases. This is basically the first echelon for nasopharynx. So critical to include for that disease subsite, as well as for any primary tumor involving the soft palate or the pharyngeal wall, or again, anytime there's bulky level 2 disease. For level 7B, that's just lateral to 7A. Again, critical for nasopharynx, also hypopharynx. And so this is one that sometimes my residents will miss because it seems a little less intuitive, that you need to contour, you end up contouring quite high, many centimeters above your primary tumor down the hypopharynx. You end up tracking these retrostyloid nodes, but this is an at-risk site for hypopharynx primaries and is important to include. And then again, for anytime there's bulky level 2 disease. Okay, again, it can be almost as important to purposefully not contour these for the appropriate cases as to include. So when would you not include these? Well, typically for larynx cases, even locally advanced larynx, as long as there's not, again, bulky level 2 disease, we don't typically cover this high up into the skull base. Oral cavity, similarly, without bulky level 2, does not tend to go up there, and thyroid would be very unlikely to spread to level 7. I don't think I included it, but salivary gland cancers as well, of course, are very unlikely to spread to this area. And then most of us treat a lot of oropharynx cancer, at least in my practice, by far the most common subsite that I'm treating. And there is an opportunity here with actually some quite good data behind it to spare the contralateral level 7 lymph nodes when you're treating an oropharyngeal primary. And that can significantly improve your parotid gland dosimetry on that contralateral side, which can lead to much better salivary function for your patients after treatment. So again, just to go over, we'll do the same thing we did last time, where I'll kind of formally introduce the boundaries of this, and then I'll pull up the exact same set of slides, and we'll go through from the skull base down, looking at all of these in detail. But for level 7A, it starts at the top of C1. Its medial edge is the carotid body. The lateral edge is the medial carotid artery, and the medial edge approaches midline. There is actually a medial and lateral 7A, and the medial is basically, they just say it's kind of poorly defined. So we usually, again, try not to go all the way to midline here to spare these constrictor muscles a bit. But if you have a bulky lymph node here and or primary, you'll often see contours drawn just straight across, including this whole area. Anteriorly, it's the posterior constrictor muscles. Posteriorly, it's the longus capitis muscles, and the inferior border is the top of the hyoid. For 7B, it's technically the fatty space surrounding the large vessels in the jugular foramen, but really, as you're drawing this out, it's just a continuation of level 2. So if you're already drawing level 2, which you are for the vast majority of head and neck cases, if you need to cover 7B, then you basically just track those contours more superiorly. So this does end at the skull base. The lateral border is the styloid process. The medial border is the medial edge of the internal carotid, which again is just the intersection with 7A. Anterior would be the edge of the pre-styloid parapharyngeal space, which is something that I guess I don't tend to think about it that way, but when you actually look at this, the contours are fairly straightforward because you're just covering the fat space, which shows it very nicely on most CT scans. Posteriorly would be the C1 vertebral body, and then you're ending at the lateral process of C1, which of course is where level 2 starts. So I will bring this back over, and we'll go all the way here. Okay, so here's the most superior slice without a level 7 contour. And then you can see basically as soon as the jugular foramen comes into play at the skull base, we are getting to level 7B. That's this maroon red right here. And that tracks down. Will be joined by 7A shortly. So 7A is in light green here. And so you can see again, it's basically just the fat space right here. And then you don't need to go track all the way to midline to include the muscles here. Again, these are constrictor muscles. So if you're over covering these, that can have effects on both short-term and long-term swelling function. When you are contouring level 7, the order of operations, what I like to do is I like to put in my parotid contour first. And I like to spend a good amount of time to make sure that I'm really confident in my parotid, because if you are electively covering this, you know that there shouldn't be any reason to electively cover a contour into the parotid gland. But if you don't have your parotid contour on, it's very easy just to sort of draw like this, and you end up having your PTV then ends up extending here. And so then your dosimetrist and your planning software is fighting. The dosimetrist is trying really hard to spare the parotid, but you're also asking the planning software to cover that area of the parotid, and you're going to get much worse parotid dosimetry, or you're just going to accept a lower PTV coverage. Whereas if you're very careful about making sure these two volumes don't overlap, which is appropriate, they never should. There's no reason for elective nodal coverage overlap with the salivary with the parotid gland for non-salivary cancers. I found that helps my dosimetry out a lot, and I get better plans. So again, pretty straightforward. Tracking down here, you're just basically covering the fat space, and you're using the vertebral body. And then you can see here, boom, here's the transverse process C1, and then all of a sudden now we're into this level 2, which is the light green here. Both, it's really stark for this level 2. The way they've drawn it here, I've never drawn a level 2 like that. They're using like a 1 millimeter brush. This patient obviously doesn't have a lot of fat, at least I guess they do on their neck. I don't know what's up with this patient's anatomy, but I don't draw a level 2 like this. I would guess most of you don't either. We're usually just being a bit more generous and with at least sort of a 5 to 7 millimeter brush, which I think is appropriate. And so similarly, I don't tend to draw these as assiduously or precisely as they do here. It's something a little bit more looped, and we'll see that in a couple of example cases. But just to track these, so these RP lymph nodes, retropharyngeal, which is the 7A, these do go more inferiorly. For patients where you're very confident that these do not need to be included, you can confidently end your level 2 contours. You can put the medial border level 2 contour at this carotid artery, and that does, of course, give you better dosimetry for sparing these medial structures, the oral cavity, those constrictor muscles, and pharynx. So again, in the vast majority of cases, I'm at least kind of going to here because that's just sort of where the fat space ends, and I'm usually not making this very, very tight margin here on the artery, but for select cases, when you're very confident that you don't need to include them, I think that's appropriate, and you certainly don't need to track this far towards midline if you're, for cases where you're confident you do not need to include 7Bs, 7As. So these do go, 7A does go lower as we get down here. Again, this is all just opportunity to, if you are confident that it doesn't need to be included, this is opportunity to purposely exclude. Otherwise, in the vast majority of cases, you're sort of just contouring all of this as level 2. It's typically the way we end up thinking of it, but again, formally it's different. And these do go all the way down until we get to the thyroid cartilage coming to here. Okay, so that's sort of the formal definitions of those. Here's Portillo. Okay, so here's a couple of contouring examples. And again, I think this is a nice palate cleanser after, again, those very, very tight, sort of formally defined nodal groups on the examples I just showed you. Again, I think they're super useful for seeing the formal definition of the regions, but this would be much more typical contouring style. So you can see that basically there's just a bit more generous, a bit smoother contouring. You can see, again, they're not ending level 2 right here. They're sort of looping in, and this would be 7B, which again is included in the vast majority of cases. And then just pointing out, so this is a base of tongue cancer, locally advanced T4 N1. But you can see even with that T4, it's only N1. They are not including these level 7, the 7B retrostyloid lymph nodes on the contralateral side. And again, it's going to give them much better parotid sparing on that side. So again, it's something that I do see my residents do a lot, is that they'll just take both. They're just contouring level 2, 2, 3, 4, and they just take 2 all the way up to skull base on both sides. That certainly can be appropriate for patients with really bulky disease, but there's data even for patients with small burden of middle disease. It is quite rare to have contralateral level 7 involvement for oropharynx primaries. So it is appropriate to exclude that contralateral level 7B for most oropharynx patients. And then let's see our timing here. We're already at 9 o'clock. So again, I'm gonna go straight to another practice session for us. So here's a patient of mine. This is a oropharynx primary. He had a T3N1 disease. His primary was on the right. You can see the GTV is orange. We have high risk CTV in blue, medium in green, and then low risk and elective is in purple. And so I'm now going to go. The next slide is going to show us a couple slices up from that. So I'd like everyone to please put in basically all the nodal contours you think are appropriate. At this level, we are above the transverse process of C1 at this level.
Thank you, Chris, for this great example and practice.
Absolutely. Yeah, it's fun to see everyone's contours. Very cool. Thank you all for the so much participation. It's really great to see this. I think we have some great talking points here. We can leave these on for a minute, and so we can talk through things. Again, I'm going to go to the next slide and see if we can even see my contours. So again, mine are going to be this green here. And so a couple of things that we saw when we had those contours on was that, so first of all, a lot of you correctly brought your contours up here to cover the pterygoid plate, noting there was tonsil involvement on the sides. That wasn't something I'd even mentioned at all, but I was really happy to see that. I wouldn't have faulted you if you just put the nodal contour here, because that's sort of what we were focusing on. But again, since this patient had tonsil involvement, we do want to track up to the pterygoid for that, but that's not really for nodal purposes. There was a couple contours I think swung wide to the lateral pterygoid muscle. That would be something you might want to include for locally advanced nasopharynx cases, but wouldn't usually be indicated for just tonsil involvement. And then I think the vast majority of folks got the level 7 ipsilateral coverage here, which is great. On this patient, I chose not to cover the contralateral level 7, even though it was a locally advanced primary. It was a bit of an easy decision for me because there was no contralateral disease. So sometimes I struggle a bit as to whether I should track up or not. Again, there is data even with small volume contralateral disease to not cover that the level 7, but certainly if there's no contralateral nodal disease, I think you can confidently exclude that contralateral level 7 nodes here. Going back to what we talked about a bit at the beginning of the talk, I'm never going to fault anyone if you sort of go big in head and neck. These cancers are bad and we want to cure our patients. And so I think there when you have the opportunity to and can feel confident about excluding a region, and that can really help get you a better plan. It can help your dosimetrist give you better salivary gland sparing. And so I think this is one instance when we really can. Again, there's multiple publications on this, and I think it is something you can feel confident about in your practice for excluding those. We often call them high level 2s colloquially when we're talking about these in chart rounds or teaching residents, but it's formally level 7. But however you say it, when you get above the transverse process of C1 and you're on the contralateral, aka opposite side from the primary tumor in oropharynx primary, you do not need to formally cover to the skull base. You can stop at the transverse process of C1. Here's Patagonia. So here's some other examples here. And here, this is a supraglottic larynx with subglottic extension. So this is sort of tying everything together that we've talked about. So we'll stick with level 7s for a minute. This patient had involved right neck node. The person who drew this did take the level 7s all the way to the skull base. Again, it's sort of less formally defined to exclude those outside of the oropharynx. So I think that's totally reasonable. I also probably would have felt comfortable stopping at the transverse process of C1 for this case personally, because there was no disease on that side, but probably what they were thinking is somehow this patient had a contralateral lymph node to the primary tumor, and so that probably made them a bit nervous and they decided to overcover. Again, I never would fault anyone for that. I think that's totally reasonable. We don't want to miss the cancer. And then coming back to our level 6s, again, with that subglottic extension, we see they're covering the 6As and the 6Bs here. And again, this is not a thyroid. They're not looping all the way back behind the esophagus. They're purposely excluding the cervical esophagus, which is appropriate and is going to help decrease toxicity. One more example here. This would be a posterior pharyngeal wall tumor. So again, these are more rare, we don't see these, but anything involving the pharyngeal wall, which this is technically oropharynx, but we hardly ever see it. Pharyngeal wall buys you bilateral level 7 coverage of the skull base, no matter what. And then because this was extending down into the hypopharynx and piriform sinus, they're also covering level 7. And then you can see there was quite a bit of nodal burden here. And so they elected, and also significant inferior extent of disease in the hypopharynx. So then on this most inferior slice, they are covering the esophagus here. I think that's a bit of a soft call. It's hard to know how far the slice is below. Again, I would track at least a couple centimeters below the inferior extent of the GTV, but then it's appropriate to come off the esophagus. And then just to show an example of a case where the level 7 is not involved. I haven't really seen that yet, but this would be a cancer of the epiglottis. So if we look over here, you can see that they're appropriately not covering level 7. So even though there's bulky disease for this patient, it's just unlikely given the epiglottis primary, not involving any of the sort of at-risk subsites, not going down into the hypopharynx or subglottic region. So they are not covering level 7. And again, that will give you much better dosimetry inferiorly. Will really allow you to spare that esophagus. And then similarly, they actually did not cover the contralateral high level 7s, which again, this is more how I tend to practice, is I do tend to be kind of, I guess, aggressive in sparing those high level 7s on the contralateral side with the aim of trying to reduce toxicity from patients. So it is 9:12 right now. I have a couple slides on OARs I can go through quickly, or I can pause and take questions and we can go through another case.
I think let's go for organ at risk. I think it's critical, so go ahead.
Sure. So we've sort of touched on organs at risk as we've been going, but just to kind of formally discuss this topic, head and neck is always a push and pull between wanting to cover everywhere that is at risk for cancer, but also spare all of the delicate structures that drive the short and long term toxicity. And if you have to choose one or the other, if you don't cure the cancer, toxicity doesn't matter. But if you can do both, if you can cure the cancer and minimize short and long-term toxicity, that's of course ideal. And so there are several structures that we're thinking up in the higher neck. So there's those pharyngeal constrictor muscles. Those are at the midline. So those are going to be basically tracking along the midline, and I can show a picture of this in a minute, between those level 7A, so those retropharyngeal lymph nodes. Between those is the pharyngeal constrictors, and then also is the pharynx itself. To the degree that you can push those out of these structures when appropriate, that will help with acute and long-term dysphagia. And then for the nasopharynx, when we are covering those retropharyngeal lymph nodes, especially, again, they can be involved. We have to take these lymph nodes to 70 gray. They sit right next to the temporal lobe of the brain. So I've caught at least once our dosimetrists, just when they're planning head and neck, they're not used to pushing on the brain. And so they often aren't even putting that into the optimizer. So if you are treating a nasopharynx to 70 gray and close to the brainstem and or temporal lobe, critical that you push on that. It's often easy to achieve this Dmax less than 66, but if you don't tell your researchers to push into it, it's very easy for 70 gray plus to drift into the temporal lobe because the optimizer is just not pushing on unless you tell it to. And think about the low neck, so the thyroid. Of all of these, thyroid is the thing I'm least caring about or excited to try to spare. We do and we can, but there are thyroid. Even if you exceed constraints, it's not a given that they're going to have thyroid toxicity. It's usually a delayed toxicity years down the line, and there, of course, are thyroid replacement pills available. All being said, there's no reason to treat through the thyroid if you don't have to. Again, we talked about when you can exclude those level 6 lymph nodes that are sort of surrounding the thyroid. And so when appropriate, which it often is to exclude level 6, it's usually not hard to meet these constraints at all. And so I certainly would say push on that when you need to, but when you have a low neck primary, of course, I should go out saying if you have a thyroid primary, we're not trying to constrain the thyroid, but a low neck primary, a subglottic or a hypopharynx primary, you likely won't be able to meet your thyroid constraints, and I would definitely not even have your dosimetrist push on it. It's much more important to get the adequate coverage than to try to maybe spare the thyroid, which again is something you can deal with, assuming these patients live long enough to have a thyroid problem. The larynx, on the other hand, unless you have a larynx primary, which again, you should not be sparing the larynx for a larynx or a hypopharynx primary. But if you have an oropharynx, oral cavity, it should be relatively straightforward and common to push on the larynx, push quite hard, and usually can meet these constraints in a straightforward fashion. And the esophagus, again, is either easy to meet these constraints if you have a more superior primary, or very hard if you have a hypopharynx, subglottic, thyroid primary. You're probably not going to meet these constraints, but these are sort of what we would push for when possible. So I know we have now 13 minutes left of translation. I can show some contouring examples of those OARs if that's helpful, or we can take this whatever way is most helpful.
I think that's helpful, Chris. We have a question about what constraint do you use for brainstem, especially when you are covering all the retropharyngeal nodes?
Yeah. So I mean, 54, if I can do it in a select clinical case, I take the surface up to 60, but that makes me uncomfortable.
Okay, perfect.
But yeah, definitely not 66 the brainstem. 60 would be the hottest I would want to go. That's a great question.
I'm a little nervous. I feel like that when I go up to 60. I think that's
Yeah.
right?
I think it certainly is possible. I mean, in lots of primary brain malignancies, things like that. But I don't like doing it. We're doing concurrent chemo, so it makes me nervous. I push really hard on it. If there's a couple of pixels or something that's over, because there's just gross disease basically abutting the brainstem, then I will take the very surface of it. But I'll certainly push really hard, as hard as I possibly can, on that to not have to cool it off as soon as we get below the surface of the brainstem.
Thank you.
Great question. Okay, so we'll start here and let me pull up. So we haven't used this tool yet, but this is a website called eContour, which I highly recommend. And I also have this linked at the end of the talk. But there's many cases across all disease sites that have wonderful contouring tools you can turn on and off, basically anything, any or all that. I have a couple that are just anatomy, which I have here, and then a couple that are or the vast majority are actual cases with GTVs, CTVs, PTVs, targets, things like that. So what I wanted to show you all was the constrictors. So these again are sort of what we're trying to spare. There's different ways to draw these. These is probably like the most generous possible way to draw this, but I think it's also reasonable if you can spare this. It's often really hard. We're usually dealing with primary tumors that are somewhere along this axis. So somewhere along this axis, it's going to end up getting 70 gray. But if you can push on the areas that are not involved by tumors, and again, if you don't overdraw your CTVs into these constrictor muscles, then that has been shown to have better swallowing outcomes over the long term. I think the brain, everyone's going to be comfortable with that contour. In terms of, let's see, what else would be helpful for us here? Oh, the thyroid is down here. The thyroid is usually pretty straightforward to contour. It's just the brighter. You can get, if you have a contrast enhanced scan like this, you can get fooled. I'm trying to make this bigger. You can get fooled if you know, right next to a vessel on an individual slice, but if you scroll up and down, you should be able to find it in a pretty straightforward fashion. It's a bilateral organ. It's on the side of the larynx. If I turn off this contour quickly, you can see it's a homogeneous, lighter gray organ that again is worth sparing when you can. Let's see, was there any other? Oh, the larynx. So again, we weren't talking about larynx cancer specifically today. Larynx cancers and hypopharynx cancers, you want to include the whole larynx in your target. But for other cancers, you want to spare the larynx. And I think that's why I have this one up, because this one has a good larynx for us. So in light green here is the kind of formal larynx structure, and then getting up into the supraglottic larynx. Less important to spare the supraglottic larynx, but sparing the larynx, of course, it's the true vocal cords, so that's important for speech quality. It's really rare to see laryngeal necrosis, which I think was listed on the slide. You know, we treat larynx primaries to high doses, and we very rarely see that. So certainly, if you're seeing a non-laryngeal primary, I think you're not a significant risk of laryngeal necrosis. But for speech quality of life, which is very important, making sure your dosimetrist is pushing on that larynx, and that you're, you know, if you're treating a standard oropharynx case, you know, you're treating up here, you're treating the lymph nodes on both sides, you're tracking the lymph nodes down, and again, even if you're needing to include those RP lymph nodes, you should be able to get quite good larynx sparing with IMRT. Oh, and then I guess we have our final Zoom poll. I don't know if this is worth doing in our last couple of minutes, or if it's better just to take questions.
Yes, let's go. Okay, I will finish.
Okay, perfect. Yeah. So I think, let's see. So it looks like the vast majority of people again got the correct answer, which is C. I can see A and B are tempting because you're basically seeing the small area of air in the esophagus, but it is the whole organ is here. And so sometimes the auto contour will do that if you're using an auto contour tool. So this sometimes needs to be corrected if your dosimetrist is sort of left an auto contour in place for something like that. And then D here is sort of getting the whole organ, but just not quite carefully tracking along the edges, whereas C here is totally encompassing the whole circumference of the esophagus. I'm going to skip this one for a minute. And then, so I mentioned there's some resources here. I just want to highlight these. So this is that Green Journal article that I mentioned, and we went through the slices of this. Again, I find it really useful. When you open up the article, it's a very long article with written English language descriptions of every nodal group, as well as sort of the primary drainage of each group. But then you really want to make sure you go down and get the supplementary PDF. That's where you get those pictures that I find really helpful. And then eContour, again, we just barely looked at this, but it is an amazing resource. It is totally free to sign up. It's unlimited use, and there is a wealth of information there. So I highly recommend it to you. It has the vast majority of commonly seen cases in radiation oncology, you can find an equivalent case there that will help you a lot with contouring. And then this, we sort of refer to this as the Nancy Lee book, but it's target volume delineation field setup for IMRT. And again, it has a wealth of information and very sort of, you're looking for sort of the rules of how to do IMRT, particularly for head and neck, although they do actually include all commonly treated disease sites for radiation oncology. This is basically, as much as we have any sort of gold standard rules in our specialty, they're in this book. And it tells you very precisely of what subsites require what nodal coverage and not. So I highly recommend that as well. This one is probably available online, but technically not free. The first two I mentioned, of course, are free.